All right, diving in today, we're going deep on something called ileoparalytico. You might know it as a functional bowel obstruction.
Yeah, that's the one.
And we've got this really detailed medical document as our source.
Cool.
Going to try and give everyone listening a really good picture of what this is.
Awesome.
What causes it.
Yep.
And how it's different from an actual blockage.
Exactly, yeah.
All without getting too, in the weeds.
Right. Avoiding the jargon.
Exactly.
Yeah, I think a good way to think about it is like, for everyone out there,
Yeah.
this is something that's relevant for understanding things like how your gut is affected after surgery,
Uh-huh.
the medications that you might be on,
Sure.
and just recognizing the different types of abdominal problems that you might be having.
Okay. So let's break this down. First of all, what exactly is ileoparalytico?
So ileoparalytico
Yeah.
is basically a temporary, sometimes it can be even a complete stoppage of the normal muscle contractions in your intestines.
Yeah.
We call those peristalsis. And those are what move food through.
Gotcha.
But the key here is there's no physical obstruction.
Oh.
It's a functional problem.
So it's not like something's blocking it. It's just not moving.
Exactly.
Okay.
Like a standstill.
Interesting. Now, what are some of the common things that can cause this intestinal, laziness, I guess you could say?
Yeah, so the number one cause, the most common one, is surgery.
Okay.
Particularly surgeries in your abdomen or your pelvic area.
Uh-huh.
It's almost like your intestines get a little stunned afterward.
Oh, wow.
They're like, whoa, what just happened?
Okay.
So that's a big one. But you can also have inflammation within your abdomen, things like appendicitis, peritonitis.
Oh, right.
That can also cause it. And then you've got certain metabolic problems,
Mm-hmm.
particularly electrolyte imbalances.
Mm-hmm.
Potassium's a big one there. Thyroid issues.
Okay.
And then, of course, certain medications can really slow things down in your gut. The big culprits are opioids, the ones that are used for pain.
Right.
And anticholinergics.
Sure.
And then even, reduced blood flow to the intestines, that can be a cause.
Huh?
We call it mesenteric ischemia.
Okay, so if someone's experiencing this, what are some of the key signs that something's up?
So you might notice things like nausea, vomiting, that general abdominal discomfort, bloating, and, difficulty passing gas or having a bowel movement.
Yeah, makes sense.
And then from a doctor's perspective, when they listen to your abdomen, what they'll often notice are reduced or even absent bowel sounds.
Like really quiet?
Yeah, almost silent.
Huh.
Sometimes we call that a silent abdomen.
Okay, so if someone comes in and has these symptoms, how do doctors know for sure it's ileoparalytico
Right.
and not something maybe more serious?
Yeah, that's where you really have to combine a good clinical assessment with imaging. So you look at the patient's symptoms, their medical history, and then you do imaging tests, x-rays, CT scans. Those are crucial for ruling out an actual physical obstruction.
Right.
And the interesting thing with ileoparalytico is, on those scans, you might see these dilated loops of small and large bowel, even gas in the rectum, but there's no clear point where something's actually blocking the passage,
Oh, I see.
like a traffic jam.
Yeah.
It's just kind of all backed up.
Right. Okay.
And then you can do blood tests to check for underlying causes, things like those electrolyte imbalances.
Uh-huh. So how do you get things moving again? What's the treatment like?
So the main approach is really supportive care.
Okay.
It's about giving your bowel a break. That means no eating or drinking. We call that NPO.
Mm-hmm.
You get fluids through an IV, correct any electrolyte issues, and really importantly, you treat the underlying cause if you know what it is.
Yeah.
And it's important to note that surgery usually isn't done for the ileo itself.
Okay.
It's for whatever condition caused it.
Gotcha.
So you got to treat that root cause.
Now, our source mentioned Ogilvy syndrome. What is that exactly?
Yeah, so that's a really specific type of functional issue where you get this massive dilation, but it's just the colon.
Just the colon.
Yeah, and there's still no physical blockage.
Okay.
And that one tends to happen in patients who are already pretty sick.
Oh, wow.
And it does carry more risks.
That's good to know. Now, to help remember all these common causes, there's a handy mnemonic, right?
Oh, absolutely. Think of the 5 Ps.
5 Ps. Okay.
So you've got postoperative,
Okay.
peritonitis, or any kind of inflammation,
Right.
low potassium,
Mm-hmm.
opioids,
Yep.
and pelvic or spinal trauma.
Okay. That's helpful. So let's get into why this happens in the body. What's going on at the, physiological level?
Sure. So it's really a combination of a couple of key things.
Okay.
One is what we call neurogenic inhibition.
Okay.
So imagine what happens after surgery. Your body goes into this stress response mode,
Uh-huh.
right?
Yeah.
And that can activate your sympathetic nervous system, the fight or flight system.
Right.
And when that gets kicked into gear, It slows down the parasympathetic system,
Oh, okay.
which is the one that normally keeps your digestion moving.
So it's like it throws everything off.
Exactly.
Yeah.
And then you've got inflammation locally right there in the gut.
Right.
And that releases substances that can directly inhibit the muscle contractions.
Interesting.
So that's one side of it. Then you've got chemical inhibition,
Okay.
where certain molecules, things like nitric oxide, can actually cause the intestinal muscles to relax.
Ah.
And like we talked about, low potassium levels.
Yeah.
And those direct effects of opioid medications, those all contribute too.
Okay, so when a doctor is examining someone, what's a really key finding that suggests ileoparalytico?
So one of the big giveaways is those reduced or absent bowel sounds.
So it's really quiet.
Yeah.
That's so interesting.
Whereas in an early mechanical obstruction, you might actually hear increased, like high-pitched bowel sounds.
Oh, because it's trying to work harder.
Exactly. It's trying to push past the blockage.
Okay.
But with ileoparalytico, things are just quiet. The abdomen might be distended, but it's not usually super tender.
Okay. And what about those x-rays and CT scans? What do those show specifically?
So on plain x-rays, what you'll often see is this widespread distension of both the small and the large bowel.
Okay.
And importantly, you'll still see gas in the rectum.
Oh, right.
Now, CT scans, those are even better because they can confirm this pattern and really rule out any physical obstruction.
Uh-huh.
And they're also better for identifying underlying causes like inflammation or problems with blood flow.
Okay, so our source had a really good comparison between ileoparalytico and mechanical obstruction.
Yeah.
What are some of the key differences there?
Okay, so think about the type of pain first.
Okay.
With a mechanical obstruction, the pain tends to be colicky, kind of comes and goes in waves.
How interesting.
Whereas in ileoparalytico, it's more of a constant discomfort. And then vomiting, that can actually become feculent later on in a mechanical obstruction.
Oh, yuck.
Yeah, not pleasant.
Oh,
And that's less typical with ileo.
okay.
And then you've got the pattern of the abdominal swelling, the types of bowel sounds we hear,
Yeah.
whether there's gas in the rectum,
Mhm.
and then, of course, what the imaging shows.
Right. Yeah.
Specifically, whether there's that clear point where the bowel is blocked.
Okay.
Those are all clues that can help us differentiate between the two.
Gotcha. So it sounds like the treatment really focuses on giving the body time to recover.
Absolutely. It's primarily conservative management.
Okay.
So bowel rest, IV fluids, correcting those electrolyte imbalances, those are really the cornerstones.
Uh-huh.
Now, sometimes we might use what's called a nasogastric tube.
Yeah.
That's a tube that goes through your nose down into your stomach,
Right.
and that's for persistent vomiting or if there's a lot of distension.
Makes sense.
We also try to minimize opioid use as much as possible. And medications to actually stimulate bowel movements, those aren't generally recommended for typical eleo,
Okay.
although there are some exceptions.
Like what?
Well, in cases like opioid-induced eleo, we might consider medications called Pomoras,
Pemors. Okay.
but those are specific situations.
So really trying to avoid strong medications if possible.
Yeah, exactly.
And what about when ileoparalytico happens specifically after surgery?
So that's called postoperative ileus,
Uh-huh.
and it's usually expected to resolve within about 2 to 3 days after surgery.
Okay.
But if it lasts longer, it can actually prolong your hospital stay.
Yeah, that makes sense.
And certain things can increase the risk.
Like what?
Things like open surgery as opposed to laparoscopic surgery,
Okay.
longer procedures, a lot of manipulation of the bowel during surgery,
Uh-huh.
fluid overload, opioid use, and not getting moving soon after surgery.
Oh, right.
So that's why these days we have modern recovery programs. They really emphasize minimizing opioid use, early feeding, and getting patients up and moving as quickly as possible.
So it's really about getting things back to normal if it peaks.
Exactly. Jumpstart that recovery.
Awesome. Okay, so for anyone listening, what's the one key thing to remember about ileoparalytico?
I think the most important takeaway is this. It's a temporary problem with how your bowel moves.
Uh-huh.
It often happens after surgery, or it could be due to medications or other medical conditions.
Right.
But it is different from a physical blockage.
Right.
And recognizing the symptoms and understanding that difference, that's really crucial for getting the right care.
So you're not freaking out unnecessarily.
Exactly. Knowledge is power.
Totally. That's a really good summary. And here's something to think about. given how often we use opioids for pain management and how many abdominal surgeries are performed, I wonder how advancements in pain management techniques and surgical techniques, how those might help us reduce the frequency and the duration of this postoperative ileus.
That's a great question.
Something to ponder. Well, thanks for diving deep with us today. This was a really informative conversation.
My pleasure. It's been fun.
Yeah, always good to chat.
Absolutely.
Thanks for listening, everyone.